It's lovely to see you. Thank you for having some of you, your cameras open. It's always nice to speak to human faces, even though they're in boxes rather than black screens with names. And what I hope to do is, because we have 2 hours together, first of all, we'll take a health break at 10:30. So if somebody can remind me that it's 10:30, we'll go get some coffee, go to the bathroom and come back refreshed, do some stretching and yoga in the middle, all of that in 5 minutes. But the other thing I was planning to do was to stop the slides every now and then and open up a conversation, a discussion, a question period, rather than talk for like an hour and a half and then only have a discussion at the end. Okay, so I'll present like a segment of the talk and then we'll discuss and then I'll continue. That's my way of making this more engaging. You're welcome to ask questions in the chat, and you're also welcome to just jump in as if we are in a room together and you're just interrupting me. My view switched. Okay, better. My name is Vardit Ravitsky. I'm a professor of bioethics at the University of Montreal in Canada at the School of Public Health. My secondary affiliation is at the Center for Bioethics at Harvard Medical School. So I am mostly in Canada, but sometimes in the US. I worked previously in several countries in the Middle East, in Europe, at the NIH, and I was faculty at the University of Pennsylvania before coming to Canada. So I have what you might call international perspectives. And one thing that interests me particularly is culture, the way our cultural identity shapes the way that we see issues in bioethics, where we come from, our personal baggage, our story, our journey, and also the community that shaped who we are, that shaped our identity. I'm a very relational person. I think people don't develop in a vacuum. They develop through a conversation with their social environment. And when I use the term culture, I mean very broadly, it includes but not religion, but not limited to religion. Obviously, some of us do not have a religious identity. We still have a culture. So this concept of culture will come up several times today as we talk about one of the most fundamental things that human beings do, which is to have children, to reproduce. And the way we have babies is changing. It's changing quite dramatically. New technologies are allowing us to experience pregnancy in a very different way than we did in the past. I wish we had time to go around the virtual room so that each one of you could introduce yourselves, tell me about your background, tell me whether or not you have children, whether you have personally experienced prenatal testing, but we cannot do that. So what I'll do is I won't assume any prior knowledge. If I describe a technology, I'll explain what it is, what it does. If I describe a concept in bioethics, I'll define it. If I take something for granted that I should have explained, just stop me right away and say, hey, what do you mean by this? Okay. But the point is to make this accessible to anyone with any level of knowledge, either in the science, technology, medical aspects, or in the bioethical, philosophical aspects. Because this is sort of this conversation that we're having today is a meeting point between technology and ethics. So I'm going to start sharing my screen to go through the first set of slides. But again, I have enough slides to talk to you until tomorrow morning, including the night. Okay, so I have no ambition to necessarily get to the end of my slides. What I want to do is have an interesting conversation with you. And the title that I offered Anna and Lacey was about the global emergence of this technology of prenatal testing. But before we get to the global stuff, like what happens in different countries and what are the similarities and differences, I gave you the paper to read. I don't know if you had time. I want to start with a more basic introduction to prenatal testing, sort of touch on the fundamental ethical issues, and then we'll slowly get into the international aspects. So I'll start by sharing my screen. Lacey, just thumbs up if it's okay. So I'm plugging in my Twitter handle. I tweet often about developments in bioethics, reproductive technologies, genomics. If this kind of stuff interests you, I'm inviting you to follow. I also tweet about all the talks that I give and all the papers that my research team publishes. So again, it's a good source of information if after today you're interested in the topic even more, I hope, than right now. I'm starting by acknowledging our research project that is responsible for some of the data that I will share with you today. So this is called the Pegasus Project. It's a national Canadian study that looks at the implementation of this new technology, non-invasive prenatal testing. And you see here the website, because all the papers that we published on bioethical issues out of this project are on the website. So that's a good place to find everything that we have written. So, oops, I have an issue of order. Okay, so I want to start with the big question of why prenatal testing? You know, for centuries, women got pregnant, knew nothing about their fetus throughout the pregnancy, and then had a baby. Boy, girl, able-bodied, disabled, healthy, sick, these things we found out at birth. And for the last several decades, we have developed technologies that allow us to sort of peek into the womb and know quite a bit about the fetus during the pregnancy. And I want to stop bioethics sometimes is about asking the right questions where nobody else sees a question. I'm asking why. Why do we want to know? Why do we want to have information about the fetus before birth? And the paper, one of the papers that I recommended for you to read in preparation for today, says that, in fact, when we look at the history of prenatal testing, we see two rationales. The first one is what I call the public health rationale. And my argument is that this one has been implicit, concealed, and unspoken. And in a minute, we'll see why. I know this is a bit of a dramatic presentation, but it's for the purpose of contrasting. The second rationale of prenatal testing is reproductive autonomy. And I argue this is the agreeable face of prenatal testing. This is what we think of as justifiable and convincing. So now let's look at what these rationales are. So when we think of testing the fetus as a public health initiative, we're actually thinking about reducing the incidence of disease or the burden of disease. We're testing to screen out certain conditions. And if you think about it, considering we cannot treat the fetus during pregnancy, what we're actually, the message that we're sending women is that we have this implicit expectation that if the fetus is diagnosed with a condition, with a disease, this diagnosis will be followed by termination. So obviously, this is not something that we fully, as a society, want to acknowledge. You know, we don't want to live in a society that puts pressure on women to test the pregnancy in order to terminate certain pregnancies, which is why what we put forward is the reproductive autonomy rationale, which says we're testing fetuses not because at the level of public health, as a society, we want to reduce the incidence of birth of sick babies, but rather because this is all about the individual woman or pregnant person. We want to provide information to expand the pregnant person's options. We are promoting informed choice. This offer is voluntary, free of pressure. It's supported by non-directive genetic counseling, so women are given all the information without any, without being given any direction or any instructions or strong recommendations about what to do with this technology. And all this is expressed through informed consent. So we're offering women access to information about the fetus during pregnancy, free of pressure, non-directive, based on informed consent, and it's all meant to promote their informed choices. But we don't have a social agenda where we expect women to test or not to test, to terminate or not to terminate. This is all about autonomy. Okay, so this is one way of presenting sort of the underlying tension that we find within many national programs where women are offered prenatal testing by their clinicians, by their healthcare providers. And we are telling ourselves this is all about reproductive autonomy, and I'm arguing that in the back, we have this public health pressure that we're not too happy about acknowledging. So what are the challenges associated with each rationale, with each side that I just presented? So obviously, if we think of prenatal testing as a public health activity, it means that we're putting pressure on women to test, first of all. So let's compare it to another screening program. You know, people over 50 in many countries are offered colon cancer screening. Why? The point is to try and reduce the incidence of disease, right? We want to catch cancer early. This is preventive. We want to treat those who are developing cancer at an early stage. So obviously, for most screening programs, the purpose is to reduce disease in the population. And therefore, we put pressure on people to use screening programs. We encourage them. But if we put pressure on women to test during pregnancy, what does that mean? That we're also pressuring them to terminate? So some have described prenatal testing as, this is a terrible expression, but as a search and destroy mission. That we're looking for fetuses who have problems, we're searching for them with the objective of termination. What are the implications in a place like the United States where a healthcare insurance is not obvious and not everybody has it? What are the possible implications for losing coverage if you didn't test? So what if we tell people, look, your child has a condition, but you could have used prenatal testing and you could have terminated this pregnancy. So now that your child is born, that's on you. That's your responsibility. And we're not going to cover the care of this child. It's almost like taking the notion of pre-existing condition to before birth. And your condition was there. We could know about it before birth, and therefore we're not insuring it. This is currently not the situation. Obviously, hopefully it will never be the situation, but it's a concern that some people have. What about the impact of this public health rationale on disability rights? So in the bioethics literature, we see the famous expressivist argument that says, when we test fetuses for a certain condition, let's say trisomy 21, Down syndrome, which is the most prevalent genetic condition in the general population and is a condition that is targeted in many countries by prenatal testing. If we test for this prenatally, what is the message that we express to families currently raising children with Down syndrome? Are we expressing the message that their children shouldn't be here because here we are searching for them prenatally with the implicit message of termination? Are we telling them that the value of the lives of their children is somehow less than other children? What about other conditions? So this is called the expressivist argument. Prenatal testing expresses a hurtful message to families raising children with the same conditions that we are testing. And lastly, the public health rationale shares a moral space with propensity towards abortion at the individual level and maybe eugenics at the collective level, where as a society, we're saying there's a threshold of entrance into human society and your fetus doesn't meet the standard. So these are all kind of ideas that might be implicit in a public health rationale. Now, what are the problems with the autonomy rationale? I presented it as absolutely acceptable, right? Informed choice, informed consent, free pregnant people, getting information so that they can make their own decisions. Well, there are great difficulties in implementing this rationale. It requires serious counseling so that people understand what is the test, what conditions are being tested, what are my options, what is it like to raise a child with these conditions. We don't have enough resources to provide this counseling. And this is something that we found in the paper that I'll present after the break about the global spread of this technology, that in all countries, there are not enough resources to support counseling and to support informed decision-making by women. The second problem with the autonomy rationale is that it's not really in anyone's interest. And this is very controversial, what I'm saying, to fully support autonomy. So from the government perspective, if you're offering a test, a screening test to women, often your objective is to increase the uptake. If a lot of women use the test, that's your success. So what you want is actually for women to say yes to this, not necessarily for every woman to consider, and some say yes, some say no. You want to increase uptake. If you're a clinician and you offer the test to a patient and she says yes, great, you're done. She will get the results and then she'll make your decision. If she refuses the test, if she rejects it, you are facing fears of liability. What if she says no and then has a baby with a certain condition, and then she comes back to you and says, you never told me that I had an option to test? And then your clinician says, oh, well, I did tell you, we discussed it, you declined. And she says, no, I was never offered this test, I'm going to sue you because this baby would not have been born had I tested. So clinicians are facing fear of liability, which promotes routinization. It's in their interest that all women say yes. And women themselves, based on decades of empirical research, some quantitative and some qualitative, maintain what has been called in the literature the false narrative that testing ensures the baby's health. Prenatal testing has been called a ritual of reassurance. Now, the clinical reality is that nobody can promise you a healthy baby. The test checks certain conditions, and it can tell you that your baby doesn't have X, but it cannot tell you that at birth, your baby will be free of any disease, any condition, or any issue. So when women say, I said yes to prenatal testing because I wanted to make sure my baby's healthy, they frame it as, I'm being a responsible mother even before birth. I'm doing everything I can to promote the health of my baby. But in fact, if the baby has an issue, there's no treatment. It's either have the baby this way or terminate. And also genetic testing only, well, it's not just genetic, prenatal testing only looks at certain things. It cannot ensure zero problems, or it cannot ensure health. So that's why it's called a false narrative. So you can see that the autonomy rationale also have its issues. Obviously, the autonomy rationale also faces disability rights critique, because women who, or families who choose prenatal testing are, I don't want to use the strong word accused, but are perceived potentially as having a negative attitude towards disabilities. So if I tested to find out whether my fetus has trisomy 21 Down syndrome, that means that I don't want a child with Down syndrome and that I'm considering termination for this reason. So I myself as an individual have biased view against people with disabilities, or so it's shouldering individual women with responsibility for the societal implications of their decisions. So if you think about it now from the perspective of a pregnant person, if you say yes to testing, you have a negative attitude towards disabilities and you're increasing eugenic tendencies in society, if you say no to testing, you're not a responsible mother and you're not promoting the health of your future baby. So in a way, this technology traps women, and not in a win-win situation, but rather in a lose-lose situation. Now, of course, this is all has to be put in context. This, there are also a lot of benefits to the technology, and we'll get to them in a minute. So my argument is this, that sometimes the reproductive autonomy rationale is a smokescreen. It's the platable theoretical framework that is not implemented in clinical practice. And we know that for many years, prenatal screening was not fully supported by informed consent. The autonomy rationale is not innocuous. It allows us to absolve ourselves of facing societal issues. Now, these are, again, controversial claims, but I want to discuss with you this tension. My bottom line argument is this. If implementing prenatal testing based on the autonomy rationale at the individual level is a lost battle, because we're not able to really promote free choice and informed consent, then we must at least protect it at a societal level through policy. So this was very theoretical and maybe not the most intuitive way to get into the topic, but I do want to stop at this point and see if you have any questions about this framing that I offered of, on one hand, prenatal testing as looking at a population level for conditions to be eradicated. And on the other hand, prenatal testing as just promoting the ability of each family to make decisions based on their own values and their own choice. So questions, comments at this point? Lucy, please. And then Jaya.
So I'm based in the UK. I'm a doctor, and I'm a member of a couple of social media groups for physicians who are also mums. One of the groups is Dr. Mum's group with children with additional needs, be it health or kind of learning difficulties, that kind of thing. And there've been a lot of discussions recently surrounding this topic, because there are quite a few mums there who have children with trisomy 21. And in the group of general doctor mums, there's a lot of talk about wanting in the UK, we have the NIPT test, the Harmony test for prenatal testing that you can buy, and people using quite negative language in terms of, like you say, this reassurance of a normal pregnancy and a normal baby, and describing the need for testing as basically wanting to avoid this burden of disease, like you mentioned, and that's within a community of doctors. And obviously the group of women who have children with trisomy 21 are finding that the real issue is not necessarily the testing, in that many women want to be prepared for the potential outcome, but more that there is a real culture in the UK, I don't know if it's the same in America, a very negative culture around when you're consenting for the testing. Like you say, it's done in a negative kind of way that almost suggests immediately that the parent is going to want to terminate the pregnancy. And so the main drive amongst these women is wanting to change the language that's used, not necessarily to take away the testing, because a lot of these women had testing, they knew they were going to have a child with trisomy 21, but it's the language that's used on the background of that testing that seems to be the problem. I'm not sure, I think I'm rambling, I'm sorry.
No, Lucy, thank you very much for this. First of all, the next set of slides is about NIPT, Harmony, and this technology, explaining what it is and why it's changing the landscape. And then after that, I'm actually talking about the UK specifically, as a case study for what happens when you implement this technology, because very interesting things happened in your corner of the world. So I'm using you as a case study. So I'll get to everything that you asked in great detail. But I want to use your question and also the question from Philip in the chat to say two things that maybe I should have started with, and mea culpa, I took them for granted. The first one is that these technologies are great, okay, for women who are actually informed about what they're choosing and who actually have the autonomy to decide what's right for them. This is amazing because we all want information. Back to culture, we live in a culture where knowledge is power. And as patients, we always want more and more and more information. And these technologies allow us access to information that we didn't have before. And the information is improving, the risk is reducing. Great. Okay, so the benefits to me is so obvious that I didn't even mention it, but of course I should have started with, these are great technologies with great potential benefits, and empirical research consistently shows that women want this. Women want the testing, and they want better tests. What do I mean by better? We'll get to it in a minute. Obviously with less risk to the fetus and more reliable information. So we have to first of all acknowledge the good. Okay, women want this, and when done right, these are great beneficial technologies. I jumped straight into the issues of framing, language, as you said, Lucy, we'll get to this in a minute, the issues of societal context in which this is offered. Because if I am just a pregnant person, independent of all pressures, I have all the money in the world, all the resources, all the family and community support, I have full understanding of all the conditions that are being tested, I have a full vision of what my life will be like with this child, that child. In those ideal circumstances, I am empowered, I'm autonomous, and I'm making a decision that is right for me. But how many of us actually live in these circumstances? Well, we have all the societal, family, community, cultural, individual support, all the resources, and the full understanding of the spectrum of conditions that are targeted by the technology. So again, I'm not against the technology. I am a great promoter. And I even wrote a paper that called NIPT an ethical imperative. I said it's imperative to offer this to women. But I pause at the word offer. What happens when we offer a powerful technology? Are we fully aware of all the layers and all the dimensions and all the forces that operate around this technology? And Lucy, your question started kind of unpacking, what language do we use? How is it presented? What is the culture? I am just looking to truly empower individuals and truly protect the free nature of their choices. I'm not against the technology. I'm against technology done right from a bioethical perspective. So thank you again for the chat and for you, because we should have started with yay to prenatal testing when done right. Okay, now let's stop and ask, where are the issues? So Evelyn says, am I suggesting that knowing the status of children is unethical? I'm assuming you're talking about fetuses, and I'm definitely not suggesting that it's unethical. It's absolutely ethical for every woman to do what she thinks is right for her pregnancy. That's my position. I am suggesting, I'll just use Evelyn's question and Lucy before we go to Jaya, Annette, and Maxi. I hope I'm pronouncing all your names correctly. And Lucy, you mentioned the issue of preparation. So a lot of prenatal testing programs say this is not about termination. We're not about abortions. We're about information so that you can prepare for the birth of your child. Your child may have trisomy 21, or others may have autism, may have an illness that requires special nutrition, may have a respiratory condition that requires less pollutants. Who knows? Let's help you prepare for the birth of your child. And this is great, except that when my research my team did research on what actually happens post-diagnosis of the fetus. Does the healthcare system, does society help you prepare, or are you being judged for continuing your pregnancy? We made some very disturbing discoveries, okay? So we say, yeah, this is about preparing for birth, But then if you're carrying a fetus with trisomy 21, you're treated as an irresponsible prospective mother, even though your only option is termination. So again, at the societal level, this is more complex than just saying prenatal testing is about preparing for the birth of your child. It's a great mantra, but how does it play out in real life? Much more complicated. So I promised Jaya, and then in order, Annette and Maxi. I hope I'm in order, but I don't see Jaya anymore, so.
I'm here. Can you see me now?
Yes, I see you now, thank you.
Well, actually, I think like your answer to like the previous question, like clarified something that I wanted to ask, but I was just gonna like ask you about this, just that sometimes in the effort of like increasing a mother's autonomy, we actually like take away her sense of control over her pregnancy by involving other people in it. Like I feel like, I don't know if this is like, if this makes sense, but like do you think scanning for these genetic issues would in fact reduce autonomy in any way, because it involves third parties in a pregnant woman's decision about whether or not she wants to carry her fetus to term, is what I wanted to ask you.
Thank you, Jaya. So there are many ways to interpret your question, and I'll interpret it in a way that allows me to introduce points that I wanted to cover. I'm just using you all with your questions to progress with the discussion. I don't think that this is about objecting to what has been called the medicalization of pregnancy. Okay, some women want to reject medical intervention in the pregnancy at almost any level. They don't want genetic screening. They don't want ultrasound. They opt for how's this such sorry, rather than a healthcare provider, they'd rather go with, oh my God, I'm blacking out on the English term for when you're accompanied by midwife. Thank you. Maybe somebody there is French speaking and knows what sage-femme is. It's actually a very cute French term because femme is woman and sage is wise. So the French term for midwife is the wise woman that accompanies you, except it can be a man as well. So some people opt for a midwife, they reject any kind of testing, and they say we have medicalized pregnancy. Pregnancy is a natural process. It's a private process, and I don't want, as you said, Jaya, third parties. I don't want to live my pregnancy from medical appointment to medical appointment, going to the hospital, to the clinic, being poked and probed. And, you know, again, to me, what women want to do with their pregnancies is their prerogative. But science, history shows us that medical care during pregnancy improves the outcomes for the mother, for the future baby. We've reduced maternal mortality. We've obviously reduced infant mortality. So I think overall, medicalizing pregnancy is very important and very good, like we medicalized life, right? We're living longer, healthier, and better because of medicine, and the same is true for pregnancy. So this talk is not about anti-medicalization of pregnancy per se. It's about acknowledging that pregnancy is a very unique context for medical care. Because in almost all the cases, whatever we find in the fetus, we cannot treat. Okay, there are very few conditions that we can actually enter the uterus through surgery or give you drugs that will improve the outcome for your fetus. So when we talk about, you know, testing, screening, diagnosing, detecting things in the fetus, we hardly ever propose to the pregnant person an option other than carry to term the way it is or terminate. And that makes pregnancy a unique medical context, because with born people, we offer medicine in order to treat them, not in order to tell them that's the way it is and you have to get used to it and prepare to live with it, or well, we can always offer you to stop living, and that's you know. And again, this is fetuses, this is not persons. I don't want to get into the discussion of the moral status of the fetus because that's another talk. But medical care during pregnancy is a unique context for that reason that I just outlined. Okay, so this is not an anti-medicalization talk. This is medical follow-up during pregnancy is offered in a unique context that needs to be acknowledged, and therefore the way it's offered and the way it's framed has to be exceptionally sensitive to bioethical concerns and to what happens in society around this particular family, and not just think that we're, little atoms in a vacuum that make free, informed decisions about our pregnancies. So now I have Annette, Maxi, Rachel, and then we'll go back to the slides so that we can talk about the technology and the UK case. Annette, please.
Hi. So I understand what you're saying about like the kind of like dilemma that mothers are put in, where if they get the testing, like there's not much that can even be done for the fetus at that point. And then if they don't get it, then they don't have that information. But I think that implementing testing at a widespread level could also like in a way like benefit the children who are born with special needs, because that way then like mothers who aren't able to provide the resources for their children who they find out have special needs, they can determine that early on and then like end the pregnancy there. Whereas like if they were to come to term and then realize that they have a child who has special needs, and then they realize that they don't have like enough resources to provide for them, then I think that would be like ethically like worse. So I don't know. I think that I understand how like the widespread implications of this could be seen as like a type of eugenics thing, and that's obviously bad. But I think that also like making sure that every child who's born with special needs has like those needs met is also important.
Thank you, Annette. Wonderful comment, really insightful and important. And again, I'm going to piggyback on what you said to make a couple of points. I'll keep going back to my initial ethical position, which is women should be free to make their choices. So I am not even touching the ethics of abortion and this talk. To me, individual matter. I won't even talk about my own position. This is not our topic today. As long as a woman makes a free informed choice, her choice is just fine. Where the societal level issue comes in, as you said, is at the level of resources. So let me give you an example. For our Pegasus study, we interviewed many women. And some of them said to us, look, personally, I would welcome a child with the trisomy 21 into our family. I feel that personally, I have what it takes to cope with the special challenges. Maybe I even have a friend who's raising a child with trisomy 21, lovely children, lovely life. But the community in which I live, the government that is supposed to support me is not providing what I need. And that is making me think about termination, because if I have to worry about school options, about later in life integrating, potentially into the job market, and especially what will happen to my child when I am old. We keep talking about babies and children. People with trisomy 21 live to be 60 with good medical care. And families are really worried what will happen to their children when they can no longer care for them. Will that become the burden of their sibling? Will my other child be forced to take their sibling in? These are real life concerns that people have. So when you talk about resources, to me, that brings me back to the societal level. And that's exactly the argument I'm about to make later, that to support free choice is not just about giving a patient a bunch of information. It's about creating a society that supports their decision through resources, through structures, through safety networks. And to say to a woman, here's a test, here's what it can reveal, now make your decision. She is not truly free because she's aware of the constraints that she and her child and her family will face later in life, depending on the resources available in society. Now, again, this is a controversial claim because not all governments have the same resources. You can't compare Canada and Nigeria, okay? Different governments have different ability to support such systems. And I picked random countries. I could talk about a million other, and our paper actually does that I'll present after the break. We went to several countries to check what are the issues in those countries around prenatal testing. And we discovered differences. But overall, this framing that it's just an individual choice, to me, is misguided. And something interesting is happening in the US right now, where certain states are passing laws that ban abortion specifically based on a Down syndrome diagnosis. So they are telling, their population, their public, if your fetus was diagnosed, then you cannot terminate, because that's a bad reason for termination. And those same countries same states provide very little support to families raising this child. So Annette, sorry, Jaya, where are you? I lost you on that. So those, sorry, Annette, that was your question, right? Yeah, so back to you. To ban termination and not provide the resources is indeed problematic. Because forcing families to have a child that they know they cannot appropriately care for is obviously problematic. And there was actually a beautiful piece in the New York Times written by a nun, by a Catholic nun, that said, the discourse in this country about pro-life is all about not terminate, but what about being pro-life, supporting life after the child is born? That's when life begins, and that's the support that we need. So shift the conversation from abortion and termination to how are we making sure that we are pro-life? And I loved that framing of taking that, phraseology that is traditionally about abortion and turning it into what matters, which is what resources do we provide families to support life in all of its expressions. So again, Annette, a very long winding road in answer to your question, but I think you put your finger on a critically important issue. Maxi, please.
Oh, these are just such amazing questions. I was just wondering if you could re-explain why the reproductive autonomy is not in the government's interest, because that's the only one I didn't understand.
Thank you. So I'll take as an example in California, which was the first place in the US that implemented a government level prenatal screening program. And in the documents that sort of present the program, you can see that the government is not paying attention to the difference between the example that I gave of cancer screening and prenatal screening. Public health screening programs, traditionally, historically, again, have as an objective increasing the uptake of the testing. If you're offering men after a certain age screening for prostate cancer, your success measure is what percentage of the population is testing. You have targets. You say, I want 80% of men to go through this screening, because I see that if I screen 80%, I discover X cases and I can preventively do this, and I save these many life years, and I reduce the cost of the healthcare system by treating them later on. So you have all these metrics to measure what is the success of a public health screening program for example, prostate cancer. You shift this to the prenatal context, and you have to, according to my argument, you have to get rid of all of that. It's not about uptake anymore, because if it's about uptake, you're going to put pressure on people to use it. And if we're talking about free choice, the choice has to be free of this pressure. So when you shift the public health rationale into prenatal, you have to get rid of all your usual measures. And the objective can no longer be about uptake. It can be, are those who use it making a free and informed choice? That's much harder to measure than what percentage of women used it. So if I'm introducing a new technology such as NIPT that I'll talk about in a minute, and it's a great technology, it's better than everything else, my impulse as a government will be, okay, now my target is that 90% of women in my country will use this because this is better. And I need to resist this as a government and say, no, my target is that all the women who chose this, whether it's 30% or 90%, were fully counseled, gave truly informed consent. Much more difficult as an objective. So we kind of fall back into the bad habit. good when the outside of the prenatal context, but the usual way in which we think of screening. Does that help?
Thank you so much. That makes a lot of sense.
So I had Rachel, but now I see there's the chat is exploding. So what shall we do? Rachel, can you still ask it live?
Sure. I had actually dropped a note in the chat in case that was more time effective, but essentially I was wondering about issues related to ethics and equity when you have sort of one group of maybe highly educated, highly resourced individuals that can pay for a test and can make a decision about whether to terminate relative to those who don't have those resources or that level of health literacy. And what happens when, I mean, I guess this touches on the eugenics issue, but what happens when we have people in certain racial, ethnic, or socioeconomic groups who have the opportunity to be able to terminate, if they choose to do that, a difficult pregnancy, and then we have folks in other groups who don't have the resources to be able to do that, and then perhaps we have an imbalance in incidence of problematic conditions or difficult to manage conditions in some population subgroups versus others. I think that's, I didn't have a specific question. I was just thinking about that. So your response to Annette touched on that a bit.
Great comment. You guys are amazing. It's like you're putting your fingers on all the hot spots of this issue. I almost don't need slides at all. We can just talk through this. But first of all, Rachel, I'm going to be talking about this when I compare the countries, because cost of testing as a barrier to access is indeed the #1 global issue that we found. So some governments pay for this, others don't. If they don't, you have to come up with hundreds or thousands of dollars out of pocket to even access the test. So that's the first inequity. The second inequity is, of course, in your level of health literacy and genetic literacy. Do you understand what is being tested? Most people don't. They want to know that their baby is healthy. I don't even use the word normal because in bioethics in prenatal, that's like a really bad term to use because, normal is a judgment call, it's value laden, etc. So I use the word health, which is also complex. But again, this false narrative of my baby's healthy is the reality on the ground, rather than I understand all the genetic conditions that you guys will detect and what each one of them means. So you have inequity in terms of literacy. And obviously, if you carry to term, you have inequity in the resources that you have to raise your child and the level of education that you have to understand the needs of your child. So inequity throughout the process, we can reduce it in the prenatal context if we pay for all the tests, right? And a lot of governments are moving in that direction. I mean, there are certain tests that are already covered. The better technologies are kind of moving into funding gradually around the world. But you're right, inequity across the board, huge ethical issue when it comes to the point that some people, with the future technologies such as gene editing, where people will be possibly able not just to test the fetus, but engineer the embryo in vitro and pick, the DNA. People are saying between rich and poor, we're going to have 2 human societies, because the rich will be able to enhance further and further at a genetic level their future children, whereas the rest of us will be stuck with a genetic lottery. So, with the future technologies, this conversation about equity even went as far as we risk creating 2 human societies and by exacerbating this gap. But we're not talking about gene editing. We're just talking about familiar technologies of prenatal testing. We have 6 minutes to the promised break. So what I'd like to do, if you don't mind, is go through just introducing the technology to you and how is it different than past technologies and why I think it creates particular challenges. So we painted together, and thank you again for your brilliant comments. We painted together a very complex reality surrounding prenatal testing. We talked about social concerns and culture and resources and equity, very complicated. But into this complicated reality, 10 years ago was introduced a new technology of prenatal testing. A lot of people know it by the name NIPT, which is acronym for Non-Invasive Prenatal Testing. And others know it by the commercial names of the different companies that sell this. Harmony, Maternity 21, there are different names out there. I don't want to sound like I'm promoting anything, so I won't mention companies or names. We will call it NIPT. What is NIPT? So before I touch this, I'll again say something that is probably obvious to all of you, but until this technology came around, we had two options. We could either do a screening test using a blood test of the pregnant woman, as you see here, which gave us only risk information. So what are the chances that your fetus has something? Or we had amniocentesis and CVS. We had invasive tests where the uterus was invaded, that's why they're called invasive tests, in order to obtain fetal DNA to test. And that was, still is, associated with the risk of miscarriage, because if you're inserting a needle into the uterus, you might cause infection, you might, there's a small risk of miscarriage. So for decades, what researchers were looking for was how to find fetal DNA without invading the uterus, which means without a risk to the pregnancy, without a risk to the fetus. And what was discovered about 10 years ago, well, actually the discovery was in 97, the first product, commercial test is about 10 years old. What was discovered is that cells in our body break at some point and release tiny fragments of DNA into our bloodstream. And this is called cell-free DNA. Now, each one of you right now in your blood, you're carrying a bunch of cell-free DNA, just tiny segments of your own DNA floating around, not inside cells where they usually are, okay? When you become pregnant, at about 9 or 10 weeks of gestation, what was discovered is that 10 to 15% of your cell-free DNA is not yours. It comes from your fetus. And that was the big aha moment. That was Dennis Lowe, a Hong Kong researcher who made this discovery. And the first thought was obviously, well, if we can get a blood sample from the pregnant woman and detect what DNA is hers, cell-free DNA, and what comes from the fetus, bang, we got it. For years, we were looking for fetal cells in the pregnant woman's blood, but now we don't need to find fetal cells. We can just look for fetal, tiny, free fragments of DNA in the pregnant woman's blood. Now, one concern is, what if this is a second or third or fourth pregnancy, and she still has fragments from the previous fetus? Because interesting fact, fetal cells in a woman's body stay for many years after she gave birth. I have 4 children, and I carry cells from all of those pregnancies in my body. How cool is that? Very cool, but not for prenatal testing, because then I cannot know whether I'm testing the current pregnancy. With cell-free DNA, fascinating, but it all clears out of the body shortly after birth. So if you manage to detect cell-free fetal DNA, you can be sure it's from this pregnancy, because from previous pregnancies, it's no longer there. So this was made for prenatal testing, right? This is like nature's gift to us in terms of obtaining fetal DNA without any risk to the pregnancy, just a blood test. Some have called it the long-awaited holy grail of prenatal testing. As I said, no increased risk of miscarriage. It can be done in the first trimester. It's more accurate than current screening, and by a lot. So from 85% to 99.7% accuracy, reliability for trisomy 21, different reliabilities for different conditions. It used to cost in the early days about $2,500. Now it's down to $600, $500. It's really decreasing. It's becoming cheaper, the technology. And what can it detect that increases? It started with fetal sex, is it male or female, and with trisomy 21. By now, the panels that you can buy include many, many conditions. And I say buy because, again, some governments cover the trisomies, trisomy 21, 18, and 13. But what you can purchase privately goes way beyond these trisomies. So what's happening with this technology is gradual routinization. It was novel. Few people knew about it 10 years ago. It started being offering more and more, and then governments started looking at it, funding it, integrating it into prenatal care. The routinization of this offer, it's a great thing, right? Women want this technology. As I said, empirical studies show that women are excited about this technology. It gives them better information earlier in the pregnancy without a risk of miscarriage. It's what women want, period. But the fact that it's becoming routine in prenatal care can exacerbate all those challenges of the reproductive autonomy model that I talked about. So think about a woman who doesn't want the test. And we hear this, women say this. When it was amniocentesis and they were going to stick a needle in my belly and there was a risk of miscarriage, I had a reason for refusing. I would say, I don't want testing because it's dangerous for my fetus. And that was a legitimate reason to say no. Now you're offering me, it's not diagnostic, it's still a screening test. It's only 99 point something %, but you're offering me a test that doesn't have any risk associated with it. You took away my last excuse to say no. Some women say. The fact that it's so good means that you have less reasons to reject it. So paradoxically, it increases the pressure on women to say yes to testing. And once you said yes to testing, you get onto this journey that takes you from NIPT to confirmation through invasive testing to making a decision about whether or not you're going to continue your pregnancy. And some women just don't want to get onto this road. I want to show you how this works, but it's already 10:30. How about we take a break? So as you're returning, I read the chat during the break, and I want to quickly address some questions that were raised, excellent questions that we haven't touched on yet. So Lucy talks about the fact that counseling is problematic because when clinicians and even genetic counselors describe, for example, trisomy 21 to a family, the description is biased. Research shows that that is true. The way trisomy 21 and other conditions is described to expecting parents focuses on the medical aspects, which means it focuses on problems. It will tell you that your child with Down syndrome has a higher chance of having this medical issue and another. Obviously, the cognitive limitations, the developmental delay, but mostly the focus is medical because you're talking to a medical professional. But when you talk to families raising children with Down syndrome, their stories are quite different. They talk about the joy, the emotional side, the great contribution, the rich perspectives that their child brought into their lives. And they talk about other challenges, challenges at school, challenges in transportation, challenges in after-school activity, different types of the result is that in the US, some states have legislated in favor of what they call balanced information during prenatal testing. This was called Chloe's Law because of a certain case that led to this. I'll send you after the talk today an entire chapter that we wrote about these laws and about how information is communicated. Because again, it's not just what you say, it's how you say it, it's how you frame it. There's messaging, there's nonverbal. It's a very complicated issue, how information is conveyed to parents. So I'll send you an entire chapter on this. I want to move on to the question about how prenatal care is reducing incidence of mortality. So again, this is an entire other talk, but to answer super briefly, it allows to identify high-risk pregnancies and treat pregnant women better so that they have less complications during pregnancy and at birth. And it allows you to prepare for birth. So for example, if you know the newborn will have an issue, you can have a neonatal intensive care team ready at birth. And this actually saves lives. Okay, so it's really either identifying risks to the pregnancy for the woman or identifying potential needs at birth and providing better treatment to the newborn. But again, I'm going to put this aside because it's only marginally related to our topic. George is asking about public funding coverage of these tests, very complicated. In many countries, traditional screening by serum screening is publicly funded and amniocentesis for high-risk pregnancies as well. NIPT is funded partially throughout the world. So it's a patchwork. The answer is very complex. The paper that I sent you in preparation for today about the global spread describes funding in the countries that we surveyed and gives you references for how to find more information. And finally, Carolina asked about the role of the father. We now talk about partner because in same-sex couples, there can be a female partner who is not who's not carrying the pregnancy and could be or not genetically related to the child. Families are very complex today. We can't make any gender assumptions, so we talk about partners. And the answer is that until quite recently, this was an underexplored question. But as I said, decisions are not made in a vacuum. What my partner thinks about disability, about abortion, about raising a future child obviously has an impact on my thinking and my decision. So the question is in what ways and to what degrees are partners involved in this process? In genetic counseling sessions, they're obviously invited to participate. Some partners that we interviewed told us that they feel a little bit marginalized in the process. You know, the healthcare providers really talk to the woman, they target the woman. We can definitely do better in making partners feel more included. But the bottom line is that the pregnancy is carried by a person within their body, and therefore testing decisions, you know, it's bodily integrity. You can't force anybody to test, and you definitely cannot put any pressure about termination or about carrying a pregnancy to term against their will. So the ultimate decision rests with the pregnant person. How to include partners in the conversation is something that everybody's working on. So you may not be happy with this answer, but that's what I have to say on this topic. Any quick follow-up? Can we look at NIPT in greater detail? Okay, so I want to present the technology to you by looking at the example of Canada. But if you want to kind of translate it to the US context, I mean, you're coming from different countries. I don't know. I know we have a UK participant, but you may be from all over the world. I don't know the numbers for all your countries, but in the US, if you add a zero, you're about right, because Canada has just over 30 million people and the US has over 300 million people. So I'm going to use the example of Canada because this is where we do our study. And we have just under 500,000 pregnancies a year. And of these, over 300,000 pregnancies will go through what I call the traditional screening, which involves either one blood test or two blood tests combined with ultrasound. These blood tests are looking for certain markers that are associated with trisomy, and they're more liable for trisomy 21. Again, I don't want to get into the technology. This could take us hours, obviously, but the bottom line is that if you combine these biochemical tests with ultrasound, you get a risk result, a chance. So I'll talk to you about my own pregnancy. You know, I was a very old mother, a very old pregnant woman at the age of 40. 40 is considered already a high-risk pregnancy, just based on age. And when I did this combined test, the result was you have a chance of 1 in 40 that your fetus has trisomy 21. Okay. Now, 1 in 40, or a percentage, is a very tough thing for a family to handle, because it doesn't tell you clearly or with any certainty what is the status of your fetus. It just tells you what is the risk. So based on that, many countries decided on a threshold. And that threshold, you know, any threshold is random. But the decision was at about 1 in 200, 1 in 300, the pregnancy will be considered high risk. Now, we're trying to walk away from the term risk because it's a negative term, and we try to use high chance, which is seen as a more neutral term, but clinicians still use high risk. So if your chance of carrying a fetus with trisomy was higher than 1 in 200 or 1 in 300, depending on the country, you were offered follow-up diagnostic testing. Usually amniocentesis, sometimes CVS. Again, I'm not getting into the details. The bottom line is that these tests give you a certain result. Okay, you will know the status of your fetus with this test. It's no longer chance or risk. This is the status of your fetus. But, you know, we put on this slide this big needle that, you know, to show that it's not an obvious procedure and that it carries a risk of miscarriage. So 10,000 diagnostic tests would lead to detecting about 270 fetuses with trisomy 21, but 70 will be lost to miscarriage. Now, I should have removed the word unaffected, because these are 70 fetal losses. We don't know whether or not they're affected, okay? But the cost of diagnosing about 270 is 70 miscarriages, tragic miscarriages. So when you look at this picture, you see that there's a terrible price tag to giving women or families diagnostic information about their fetus. Clear so far? Okay, so the first way that NIPT, or, you know, detecting cell-free fetal DNA in the plasma of a pregnant person, the first way that this was introduced was here. So for women who went through the traditional screening procedure, blood tests, biochemical tests with ultrasound, and got the high chance result, instead of jumping straight to the needle, they were now offered NIPT, which would still be a screening test that would have to be confirmed, but reliable at over 99%. So what does that do? Imagine, put yourself in the shoes of a pregnant woman who just got a result like me of 1 in 40. When I got that result, there was no NIPT. Okay, that was too many years ago, and there was no NIPT. So I had to decide, I continue to amniocentesis and take the risk, or I just continue my pregnancy and I don't know. Now women would have the option of going through NIPT And for example, in my case, I would have gotten a negative result. I would have been given a result that 99.7% that my fetus does not have trisomy 21. Would I have then chosen to confirm by amniocentesis? No, I would have been perfectly happy. I didn't even confirm with amniocentesis when I was told 1 in 40. Definitely wouldn't have confirmed so for many women, what this does is it reduces the uptake of invasive tests. So in Canada, when NIPT was offered in this way, we moved from 10,000 amnios to 300, but we kept almost the same detection level of trisomy 21 and almost eliminated miscarriages. So now you can see how powerful this technology is, even when it's still screening, because of its impact on the reduction of invasive tests while keeping the same level of detection of cases. What are we looking? So this is how it's implemented in most of the world today as a second-tier screening test based on the traditional screening test that already identified you as being high risk. Now you have to understand, when the private companies who developed this technology started studying it, they studied it on a population of high-risk pregnancies. So they validated it for that population. The second wave was testing it on a population of all pregnant women, regardless of their risk level. That took a while. Now it has been validated for the general population of pregnant women. So we're starting to offer it as a first-tier screening test, which means we're skipping the old-fashioned tests, the biochemical combined with ultrasound. And we can offer NIPT earlier in the pregnancy, week 9 or 10, which is amazing because it's still first trimester. You get your results much earlier. They're, we hope, as reliable. That's what our Pegasus study is testing, is it's as reliable when you do it on the general population of pregnant women as it was for high-risk pregnancies. I hope you're following that. This is a complex process, but I hope you're following this. So now we're offering it, certain countries offer it as a first-tier screening test, which means many women will be reassured, and it will cause, again, this reduction in amniocentesis, but we don't know by how much yet. We're studying this. The problem is that if you get your NIPT result in week 11 or 12, you can do CVS right away, or you need to wait for week 15 to do your amnio. And we still tell women it's very important to confirm. Don't go and make decisions based on an NIPT because there's still a chance that it's wrong. It's a screening test. It's not a diagnostic test. And some women don't want to wait until the amnio, and they make decisions just based on an NIPT, which goes against medical recommendations, but it happens. So some women choose to terminate their pregnancies based on an NIPT result and not confirm with diagnostic testing, which is really not recommended to do because it could be a false positive. Your NIPT could come back positive, and that could be wrong. Very small chance, but it could happen. So we're studying all the aspects of this move from second tier to first tier. The holy grail for real will be if NIPT gets to the point that it's reliable enough to be diagnostic, and that it's offered at week 10 of the pregnancy, and there's no need for confirmation with invasive test, that this actually gives you certain information about your fetus in the first trimester with zero risk of miscarriage. This would be really the holy grail, okay? So that's what companies are working towards. Now, when I say reliability, it depends for which condition. For trisomy 21, I said over 99.7% accuracy, but when we look at trisomy 18 on 13, it's less reliable than that. And when we look at other conditions, for some of them, it's already at 100%. For example, fetal sex. If you are a woman and you have fragments of Y chromosome in your blood, they're not coming from you. So you know that the fetus is male. So NIPT has been validated a long time ago as 100% accurate for fetal sex. So it all depends on what it is that we're detecting. The question to ask is, apologies. The question to ask is, when does consent take place in this process? Ideally, before any testing, right? Before the biochemical tests, ultrasound, as you know, we don't even ask for consent anymore. It is a medical test that happens without consent. It's also implicit. If you're lying on the table and letting it be done, then you're consenting to it. But the truth is that ultrasound is a diagnostic test that can reveal medical problems, and women are not ready for it because they think of it as, yay, I'm going to see my fetus. So for ultrasound, we dropped consent. For biochemical tests, we have consent, but it's really badly done. Many women don't even realize that the screening occurred. There's many blood tests during pregnancy. Some women didn't fully understand that this test is a screening test. NIPT, there is consent, but again, if you're purchasing this privately, the consent happens through the private company. The information that you're getting, is it biased? Is it balanced? It's complicated. Prior to amniocentesis, there's definitely consent because it's a risky procedure. So where does consent happen, and where do we want it to happen, and how is one of the big questions we're dealing with. What can NIPT currently test for? So as I said, fetal sex, and that's not just for fun to know, that's also about X-linked conditions. Blood type, I'm not going to get into this. The three most prevalent trisomies, other more rare trisomies, sex chromosome abnormalities when you have more than one sex chromosome, some single gene disordered, some microdeletion disorders, and technically, you could sequence the entire genome of the fetus based on this technology. So this really blows my mind when I think about what the future holds. For example, when my daughter, that fetus that we talked about when I was 40, she's 14 now. So when she has her children, maybe one day, what will be the options for her? And when I think about the future of prenatal testing, I'm thinking back about what ultrasound did culturally to pregnancies. And what it actually did is that it made the uterus transparent in a way, right? It revolutionized our perception of the fetus. We all leave, those of us who have been through this, we leave ultrasound with little prints, little pictures of our fetus that we share with family and friends. We now have 3D ultrasound that actually shows you your baby in the uterus, and we get little videos of our baby sucking its thumb and having hiccups. And so this technology culturally created an expectation of seeing the fetus before birth. And my point is that if whole genome NIPT becomes routine, it will create an expectation of seeing inside the fetus, seeing the genome of the fetus very early on in the pregnancy. So that by week 12, still in the first trimester, we will not only know certain conditions, but we will have anything that we know about human genetics, we will know about our fetus because we will have the full genome. And to me, that raises all the ethical issues portrayed in the film Gattaca that, if you haven't seen, it's kind of old. I think it's from '97, but it's still very fresh from a bioethics perspective, describing a society where everybody's born post-genetic selection as embryos, and what that does for equity, for discrimination, for identity, for the culture. So all the ethical issues that might arise in this future that I'm now describing are described in this movie very interestingly. So I want to take a break now in order to see if you have questions specifically about the technology, how it's implemented. This was a lot of material, so let's see what questions you have at this point. So I can't read the whole chat, but I see the last one from Lacey, from Dr. Loike, asking about gender selection. So first of all, I know a lot of people call it gender selection, but it is sex selection. Gender is an identity, and sex is the biology. And so for the fetus hasn't told us yet what it wants to be. And therefore it has a sex, but it doesn't have a gender yet. I myself once wrote a commentary about sex selection in pregnancy, and the editors of CNN changed the title to gender selection, which it's terrible because I'm signed off on this article and it says something that I don't agree with. So sex selection, very, very problematic, because in countries like the US or Canada, where there is no clear cultural preference, some people who use this actually want girls, some want family balancing. It doesn't have a social level impact. However, in countries such as China and India, where sex selection via abortion has been practiced for a long time, the sex ratio in society is already very skewed. There are, we're talking about millions of missing women, missing in the sense that they naturally would have been born, but those pregnancies were terminated. And this causes serious social harms. So in India, if I take India, for example, sex determination, fetal sex determination is banned by law. But communities are trying to override this by, for example, having ultrasound machines privately to give people information about fetal sex sort of in a hidden way. And then people terminate pregnancies, technically illegally. What NIPT has done is it allowed better detection of fetal sex in cultures with strong preference for males, in a way that helped override legal bans. So for example, NIPT companies, we were told, will send a nurse to collect blood in your home, and the sample will be sent outside of the country, and you will get your results via a secured website. And so the entire process can occur outside of the medical system. It's all private. And you can get your fetal sex in the first trimester and terminate knowing that it's a female fetus, but nobody else has to know that you know. And so NIPT has been described as exacerbating fetal selection based on sex in countries where this is already a problem. So again, there's a lot to be said about this, because this can be an issue for different reasons in different countries, but I just wanted to make this distinction between countries with a strong cultural preference for males and countries without a strong preference, where it's, probably will not have an impact at the societal level. So I don't have time to go through, I don't want to sit here and read the chat while we're all waiting. So if anybody has a question, maybe just ask it live.
Is the NIPT publicly funded in Canada? Like the full...
So Canada is a patchwork like the US. So in the US, different insurance companies offer different levels of funding. Canada, the healthcare system is based on provinces, which is the equivalent of the US states. And each province has its own healthcare system. So some provinces already made the decision and they fund it, but only for what I called high risk pregnancies. And some provinces have not moved to fund yet. So if you live in certain provinces, it would be free for you, and in others you'd pay out of pocket, which creates an equity issue because not all Canadians have the same access, which now puts a lot of pressure on the governments that have not funded it yet to go ahead and make that decision. Our study, Pegasus, is supposed to actually inform all these governments about the implications of funding. So how much money will it cost you? Can it be cost neutral because you're reducing the cost of amniocentesis? Can you use those savings to fund more NIPTs? So this is a part of our study. Okay, we have Elisa, Warren, and Lacey.
Yeah, so my question is about after we integrate NIPT into regular testing and have it as the first screening test, do you think that having more time, or the woman having more time to kind of choose whether or not she wants to terminate her pregnancy, will we see higher levels of terminated pregnancies lower levels, or like will it stay kind of consistent? I'm not sure if you have the answer. I'm just curious to hear your ideas.
Fascinating question. So at first, if you look at the bioethics literature from the first years of NIPT from 2009 to 2012, 13, everybody said this will increase the rate of terminations because more women will get information. It will be earlier in the pregnancy. You know, terminating at 12 weeks is nothing like terminating at 24 weeks, obviously. Completely different story. So the thinking was because it's earlier, more women will feel that they're able to terminate, and because it's better, we will have more detection. So overall, it will increase the rate of termination. In the UK, where this has been studied, and maybe Lucy wants to share more, we have not seen an increase in the rate of termination. So we need to study why is that, but it raises fascinating questions that we will be following up over the next years. I will piggyback on your question to make a really interesting point. During the first 12 weeks of pregnancy, the natural rate of miscarriage is very high. Many fetuses who have genetic abnormalities will be naturally miscarried by the female body. We don't understand the mechanisms, but we know that a lot of people don't tell family and friends until they cross the 12-week threshold, because people know that the chances of continuing the pregnancy are higher once you're in the second trimester. First trimester miscarriage is more prevalent than more people realize. Actually, at around 6-7 weeks, I wouldn't say half, but I think 30-40% of pregnancies end, and women don't even know that they're pregnant. They just think that their period was late and then they have a heavy period. So what NIPT might do is detect a problem in a pregnancy that would have been miscarried anyways. So if we get to the point of giving a woman results in week 9 or 10, we're not there yet, but if we get to the point of giving results at week 9, we may burden women with decisions that they would not have faced without NIPT, because this pregnancy would have been miscarried. Some people say that this is a new type of ethical issue because it creates a decision point, a new decision point, with the moral burden, the psychological burden, the anxiety, whereas we could have saved you this by just waiting. But the reality is that we always wanted prenatal tests earlier and earlier in the pregnancy to allow more time, as you said, Lisa, and to allow earlier termination for those who wish to do that. So I don't think we're going to be able to solve this problem. If we want earlier, that's a new price tag that we haven't had before. So I was just like using your question to bring up that point because it's kind of interesting. Warren, please.
Thank you. My question is just, so I understand in the presentation that you said, it's a question on technology. In the presentation, you said that the ultrasound portion and the biochemical testing portion can be eliminated with the adoption of NIPT, or that's kind of the direction that people are looking to go, if that particular step could be eliminated regarding the detection of trisomy 18 or other Down syndrome or something like that. But will that ultrasound still be performed for the detection of other issues? And the biochemical testing, will that still be performed anyways for other issues, just because of
Yeah.
Right.
Fantastic question, and it's a part of what we're studying. So when you think as a health economist, you're thinking this way: I'm going to integrate a new test for X millions of women. It's going to cost me X millions of dollars per year. Where can I save this money to fund this new technology? Obviously, you go to amniocentesis where you see a reduction. So, amnio is what, $1,500. You say times tens of thousands. This is the money I'm making that I can now cover NIPT with. But am I able to also save on the reduction of biochemical tests and ultrasounds? Great questions that people have been asking. The problem is that ultrasound detects neural tube defects and other malformations that we don't want to give up on this screening. So there's congenital issues that ultrasound will still be useful for, regardless of how it's used in combination for trisomies. And biochemical tests can still reveal information about pregnancy complications that we lose with NIPT. So it's a tough one. In an ideal world, we'll keep everything for different reasons. Hopefully get rid of diagnostic testing because it no longer will be necessary someday. But keep all the other traditional tests for other reasons. The reality is that healthcare systems are under pressure to let go of other tests for economic reasons. And that becomes a terrible ethical dilemma of, if I am taking money from there to fund more NIPT, I'm going to miss out on some pregnancy complications, and maybe I'll miss out on some congenital malformations. Am I willing to pay this price to allow more women access to NIPT? You know, here economy and ethics go hand in hand, because you're making economic decisions based on values. And that's a huge challenge facing healthcare systems around the world right now. So thank you for this brilliant question. Lacey, please.
Hello, I just wanted to offer a little bit of personal experience. If you don't mind, I'll be real quick. But some of the things that you've mentioned have kind of been highlighted in my own experience. I was pregnant with my youngest at age 30, and through the nuchal translucency combined ultrasound blood screening, came up with an abnormally high risk for my age for trisomy 21, as well as some anatomical markers that were concerning. And so the way that it was put to me, and the implementation of Chloe's law and the policy aspect of this is very interesting to me, because the way that it was put to me from the physician and the genetic counselor that were trying to counsel me on whether or not to proceed with NIPT was basically what you had just said, you know, all of the medical implications and all the things that could go wrong. And we had just moved cross country away from our support system. And I kept thinking to myself, you know, what am I going to do with my other children if I have to have, you know, be in the hospital with my newborn who needs to have surgeries and these sorts of things. So it really did influence me to undergo the NIPT testing, because I thought, well, gosh, if there's going to be all these medical complications, I should be prepared. When in reality, my NIPT testing came back negative and I didn't have anything to be concerned about, but the absence of speaking to someone who had a child with Down syndrome and the absence of knowing things outside of the medical information was really influential in my decision to proceed, because I felt an immense pressure to know what my life might look like in the first few months of my child's life, and how I could manage my other children, with my husband being very busy with his residency. And so I think it's really important that you highlighted the policy implications and things like Chloe's law coming into play with helping mothers and families identify whether or not they want to proceed with NIPT testing.
Thank you so much, Lacey. Your experience actually really resonates with testimonials that we're hearing from woman after woman. So a few points. First of all, a part of the Pegasus project is that we are in the process of preparing a website for pregnant families that provides what we call balanced and neutral information. And we're doing it in multiple ways, not just texts that have been written with great care to framing, terminology, language, etc., but also videos based on interviews we did with families raising children with Down syndrome and raising adults with Down syndrome. We interviewed a family where the parents are in their late 70s and their daughter is 37. So that's a different set of concerns than elementary school or somebody 18 trying to find their first job and getting on a bus with trisomy 21. Different sets of concerns, but you don't hear those from your genetic counselor. I actually worked with genetic counselors who have been, giving advice, counseling women and partners on trisomy, and they've never met a child with trisomy 21, never in their lives. So what kind of information are you conveying with all you have to say is chance of heart problems, structure, your scope of your perspective is really limited. So we're trying to compensate via this online resource. There's tons of videos online of families talking about their experience already. We're trying to create interactive tools where people can kind of click for more information in the areas that interest them. There's not enough balanced and neutral resources out there online. People go, turns out, to social media. They feel that they got skewed counseling, and they go to Facebook groups, they go to Reddit. We just published a paper about how people discuss NIPT on Reddit. I'm making a list of all the papers I'll send you after this talk. Fascinating. And the last paper I want to mention is called, if I recall, Having a Perfect Baby. It was written by an gynecologist, an OB-GYN, who has been counseling couples for years. And then his daughter had a child with Down syndrome. And he fell in love with this baby, his grandson. And he wrote this paper about how this lived experience changed completely his view of his clinical practice, the way he talks to families, his view of prenatal testing, because to him, this was a perfect baby. So couples talk to us about even the tone of the way diagnosis is communicated to them. Is it a somber, I'm sorry, we have news, or is it, congratulations, your baby's healthy and she has trisomy 21? You know, the framing is everything. And then acknowledging that people will go through a period of adjustment. Some psychologists call it mourning their vision of the baby they thought they were having, because now they're having a slightly different baby. This is an exceptionally complex area, but the way the healthcare system communicates is so far from ideal right now that there's tons of work to be done. So, you know, I step away from putting the moral burden on women and talking about societal issues, healthcare system issues, because we can do so much better without just putting all the burden on women and saying, here's a bunch of information, now go do the ethical thing. So that's what I'm critical of. So were there other questions? Should I go through the chat? Okay, we're totally running out of time. I was planning to go back to my two rationales and look at what NIPT is doing on the autonomy rationale front and on the public health rationale front. But I think we kind of touched on all that already through our conversation. So I'll use the UK case. Ooh, now I'm facing a dilemma. Do I do the UK test case or, you know, let's do that. Regarding the global comparison, I sent you the paper and all the information is there, okay? So if you're really interested in how different countries cope with the integration of NIPT, public funding decisions, what about countries that offer NIPT but abortion is completely illegal? Like Lebanon, you can buy the test, but you cannot have a legal, safe abortion. What does that mean? What does it mean in countries that have a strong cultural bias against people with disabilities? So in Israel, for example, there's high uptake of NIPT and disability advocate organizations support the technology, contrary to what we see in the UK, where these organizations argued against the technology. So you see a fascinating tapestry of issues based on culture, on funding, on laws. So I just invite you to read the paper. I hope I whet your appetite and that you will go and read it. But I do want to show you the UK case study because it's so interesting. Julian, quick question before we go back to the slides. Yes.
Yeah. There's an issue that's regarding the cases where the main thing that's going to affect your decision of whether or not to carry a fetus that is going to have a disability to term is a social pressure. Like it's something like, how is my child who will be disabled, how are they going to be treated by the society we currently have? I've heard two perspectives on this issue. One is like, if you're a parent, your primary duty is to your child as an individual and not to changing society generally. And the other is like, if you're a physician and you recommend to a parent, like, listen, the social reality is that a disabled person isn't going to have a good life in this society, then nothing's going to change. What's your perspective on that?
Fantastic comment. So profound and powerful. So on one hand, this goes back to how we put women, like, in a way, it's a win-win because you have better information, better access, more information, safer. At the same time, it's lose-lose because the social forces put you in a situation where you, no matter what you do, somebody will criticize you ethically. And so is your responsibility to your child, and you ask yourself, do we, as a family, as a community, have what it takes to give a good life to this child with this set of needs? And that's where my thinking ends. Or do you say, by choosing to bring into the world a child with a certain set of special needs, I'm promoting a society that is more tolerant, that is more exposed to diversity. I'm doing my little bit to fight eugenics. You know, I'm trying to find wording for what you describe. And I would just say that that puts an unbearable burden on women to be the agents of social change. So instead of all working together as a society to reduce bias and stigma and discrimination and to create resources that support families, we put all this burden on the individual shoulders of pregnant women by telling them, you will affect this change by having your individual child. So unfair. And so all my arguments and everything that I write are about the societal level change that we need to implement through policy, through changing the culture, through education of all of us, not putting the responsibility for diversity on individual families. There's actually a fascinating paper by Robert Sparrow that says we all talk about how important genetic diversity is, but who has the responsibility for maintaining genetic diversity? Individuals? How does that translate to our individual decisions? So I'll try to remember to share this paper as well. But great comments, Julia. So now in the 6 minutes that we have left, I want to share this case study with you because it touched on all the points that we mentioned and more. And it was so interesting, and maybe later on, Lucy can give you more information about this. So in 2016, the UK National Screening Committee recommended public funding of NIPT as part of the National Health Service. So they have a screening program for pregnancies. And the issue was, do we integrate NIPT into this screening pathway that already included biochemical and ultrasound and amniocentesis, et cetera? And the recommendation was to fund NIPT only for high-risk pregnancies, what I called second tier. Remember in my slide with the whole journey, public funding for NIPT as second tier, because it wasn't deemed cost-effective for all pregnant women. The calculation was based on the impact of NIPT as saving invasive tests. So they wanted to keep the same level of detection, not increase the cost to the healthcare system. So they calculated how many amnios will we save, will we not perform if we offer NIPT to high-risk pregnancies, and this money will be used for public funding of NIPT, okay? So they kind of calculated that within the healthcare system, within the screening pathway, to make it what we call cost neutral, no added burden on the healthcare system. This decision followed a period of public consultation where anybody could submit an opinion, a contribution. And the Royal College of Obstetricians and Gynecologists offered the following input during the consultation. Now think about them. As healthcare providers, they're told that only their high-risk patients will get public funding for NIPT, but women who are low risk will have to pay out of pocket. So what do they want to do? They want to increase public funding of NIPT for all their patients, right? So you have to keep in mind, this is their motivation. They want public funding for NIPT for everybody. But look how they argued for that, in favor of that. Look at that. If the decision, they're telling the National Screening Committee, if the decision has been made primarily on cost grounds, then they want to change the economic picture. A more rigorous economic analysis has to be made that, and I highlighted this, that includes the lifetime costs of caring for children and adults with Down syndrome. Such an economic analysis may suggest that NIPT for everybody is cost effective. The National Screening Committee said we can only take money we saved from amnio and count that as funding NIPT. The Royal College of Healthcare Provider of Relevant says, no. Let's also think about the cost we're saving from all of the kids that will not be born with special needs. So let's take what it costs to care for a child for the rest of their lives and calculate that as a bucket of money that we can use to fund NIPT. Everybody with me? Now, the ethical issue, I hope, is screaming for you here. So in September of that year, more than 100 healthcare professionals signed a letter attacking this recommendation. The letter accused the college of advocating that women with a prenatal diagnosis of Down syndrome should end their pregnancies. Because if you're calculating the money you're saving when a pregnancy is terminated, it's like you're telling women, be a good citizen and terminate because you're saving us money. Public outcry followed. Media articles condemned this view. Celebrities and doctors who have children with Down syndrome said that they were shocked, horrified, terrified. Articles highlighted the value of individuals with Down syndrome for society and expressed fear of eugenic tendencies. So here are some of those articles. 20 members of parliament signed a motion in support of a campaign titled "Don't Screen Us Out." There were demonstrations. This is a beautiful child with Down syndrome holding a sign saying, "NIPT, no thank you, I'm perfect." So this "Don't Screen Us Out" is a campaign ongoing. You can still find it online. It says NIPT harms babies with Down syndrome and the Down syndrome community. Introduced under current conditions, it would enable eugenic discrimination. So the backlash was, don't fund NIPT at all. The Royal College wanted more funding. The backlash said, no funding at all, because this sends a terrible message to the society in general and to our communities. So my argument based on this case study is, even if informed consent is a lost battle and women will not fully understand what NIPT is about at the individual level, we must protect and promote autonomy at a societal level via policies that reduce pressure on women and allow them viable options. So in the paper that I asked to share with you, The Shifting Landscape of Prenatal Testing, I'm making very specific recommendations. And the number one is that when we calculate the cost effectiveness of NIPT, we never include savings associated with prevented lives. We only calculate savings from other prenatal procedures. But we draw a line at birth. We never consider any costs or any savings beyond birth. The other thing that we already discussed is that the objective of the program can never be increased uptake, but rather increased offer and informed and free decision-making. All of this is in all the papers that I shared. I'll send a bunch of papers that were mentioned during the talk, and you can go to the Pegasus website to find a host of empirical studies, interviews, surveys, comparative between different cultures and different countries. There's tons of literature on this, but I hope that we used well our 2 hours together to put our finger on the most controversial topics, and I hope that this whet your appetite to do a lot of reading on the topic. Thank you so much. Your questions and comments were invaluable in helping us progress and going deeper and deeper into the issues. It was an absolute pleasure to spend this time with you.